Great. And so welcome everyone. Thank you for joining us for this very interesting presentation on Choosing Wisely, an international campaign to decrease unnecessary medical care. It's my pleasure to hand the presentation over to Dr. Wendy Levinson, who is the Chair of Choosing Wisely Canada and Professor of Medicine at the University of Toronto. So welcome, Wendy, and I will just move the presenter ball over to you so that you can control your slides, and please go ahead whenever you're ready.
Great. Well, I don't know whether to wish people good morning, good afternoon, or good evenings, because it depends on where you are, but I'm happy to have this opportunity. I'm sure that most of you come, or I would think most of you come from a background where you work with government or agencies that are related to government or to payers who assess technology and whether it should be paid for in the health system. But what I'm going to talk about is a kind of very different approach and one that, might be complementary or achieve similar goals, but from a very different standpoint. So what I'm just going to do briefly is talk about the epidemic of overuse. I know this is something you're aware of, but I kind of want to put it in context. I'll describe the Choosing Wisely Canada and International campaign. I'll definitely draw on Canada because that's where I am and I have the best on-the-ground information about it. But I'll give you sort of examples of how it's being implemented both in medical education and practice. So to start with, this is a slide that probably all of you have seen. It was published in JAMA in 2012 by Don Berwick, who created the Institute for Healthcare Improvement and was head of Medicare Medicaid Services, as most of you probably know. And the slide really, which he calls the wedges of waste, says that whatever the rise in the % of gross domestic product spent on healthcare, and of course all of our countries are concerned about this, that what he was demonstrating in this slide is that a percentage of what we spend, whatever that amount is waste. And by that he meant things we do, either tests or treatments, that don't add value to our patients, and in some cases I would say are even harmful. So for example, a wedge of waste is the failures of the care delivery system where our diabetics get end-stage complications instead of having had appropriate prevention, failures of care coordination. We have this a lot in Canada where the emergency room physician can't see the results of the family doctor's testing, and so they order it again. And then a big wedge of waste that Don Berwick called overtreatment, and I would call it overdiagnosis and overtreatment, and in fact it's the diagnostic end that's most of interest to you. And overall, the Institute of Medicine in its reports estimated that 30% of all of healthcare delivered fell into this basket of waste, meaning that it didn't add value for patients and could even be harmful. And what's interesting is, I thought when I've been involved in the campaign since it began in the U.S., but I thought the Canadian percentage would be a lot lower, that would be a very American number because of the way the healthcare system is structured in the U.S. But in fact, I can tell you that this 30% number seems to appear in all the research that we're doing in Canada about overuse. So I'll share some of it with you. So of course, I always say, I'm a practicing internist. I always say I don't get up in the morning thinking I'll go to work and try and address this social problem, or I'll try and decrease the percentage of healthcare spent on GDP spent on healthcare. I get up in the morning to work with patients one-on-one, and patients often say to me, so why is it that physicians would order a test that isn't needed? Like, that doesn't make sense to patients. And I always say it's really a variety of reasons that are these bubbles in the doctor's head. Patients want it. That's the patient whose neighbor had a brain tumor and they're having headaches and they'd like a CT scan. And that's a particular problem in the primary care setting where patients will come in with expectations and doctors want to meet them. A second is that both patients and doctors are enamored with new tests. We kind of have a culture where new is better. more is better for sure, and so there might be expectations that we should do the latest technology. And in the U.S., of course, there's direct-to-consumer advertising about this new technology. Third, it says better to do something than nothing. I think there is an expectation that when you go home, if you didn't get a prescription or a test, you didn't get care. And physicians will say that it takes more time to tell patients why they don't need that MRI for low back pain than just to check the MRI box on the requisition. So that's an issue. There's a bit of back and forth between specialists and primary care doctors, certainly in North America, but I bet everywhere, where specialists will send back a referral that says to the primary care doctor, do the following tests. The primary care doctor might not think they're necessary, but the specialist says to do them, so they do. And similarly, specialists might be referred a patient to get a particular test, like a stress echo of some kind, and they want to meet the primary care doctor's expectations. So there's a bit of that back and forth. Another bubble, particularly in the emergency room, is I don't want to get sued, so I leave no stone unturned and order that extra test. There are certainly misaligned financial incentives in some countries where you paid more for doing more tests. But I think the last bubble is the most important bubble, and that is doctors learn to do it a certain way. I've always done it this way. Whenever I see a patient with this situation, I work them up with the following tests. And there's a lot of research I won't go into, but that shows that once doctors embed these patterns of practice, they're quite hard to change them. So there really are a whole host, and there are probably more, things that contribute to why physicians order tests that are not necessary or might even be wasteful or harmful. So I think this is the way Choosing Wisely frames the problem, and I'll show you it underpins the approach to the problem. So really the campaign in Canada and the U.S., I was involved in creating in the U.S. I was on the board chaired the American Board of Internal Medicine that created the campaign and its foundation. It's really a campaign to help clinicians and patients engage in conversations about unnecessary tests and treatments and help patients make effective choices for high-quality care. And the statement is quite important, that it really is about stimulating this dialogue. It's not to say you should not do these things. It's to say, talk with your patients. Don't do them routinely. And to patients, ask your doctor. It's to stimulate this conversation. And what you don't see in this statement is cost. This campaign is really focused on providing high-quality care and preventing harm. And it's focused on where doctors live and breathe, which is in the exam room, talking with patients about making good choices. And I think that this is fundamental to why it has been so widely taken up around the world. So I'll talk about that more in a minute. So the campaign approach, let me just look at this. Sorry, I think I moved ahead one slide. Yeah. So what's unique about Choosing Wisely is the following things. One, it is clinician-led. It's not a government saying this technology doesn't add value, we're not going to pay for it. It's clinicians themselves, based on science, making suggestions to their colleagues. It's very much bottom-up. It's focused on common clinical conditions, not the rare thing that needs sophisticated technology. It engages both primary care and specialty physicians. It's extremely simple. It's not like guidelines. You'll see that these are just very simple statements, and it really has experienced just a remarkable uptake, I can tell you, about Canada recently. So the campaign approach has multiple planks. The first is through physicians, and then I would say, and other health professionals who come in, like nursing and pharmacists, et cetera. And the societies each have created a list, and I'll show you these lists in a moment, of 5 things in their discipline for which there is excellent scientific evidence of overuse, waste, or harm. And so these lists are the core of the campaign. They're through national societies, typically, and then the society can disseminate these lists through their annual meetings, their publications, etc. Secondly, there's a patient plank, and I'll show you what we're doing in Canada and the United States. The campaign worked very closely with Consumer Report, which some of you may know is a highly respected brand in the United States, who helped to develop and disseminate patient education materials. Third, we've tried to work with the media because it's hard to reach the entire public. We've had very good uptake of this in Canada, including recently. And then fourthly, we're small operations. We try to bring together the stakeholders that could be hospital associations or medical associations or measurement groups that can influence and implement Choosing Wisely. So it really is about engaging the stakeholders. In the United States, this might be different groups like Kaiser. In Canada, it could be a whole province like Alberta that have taken up the campaign to try and implement it. So here's what the lists look like. So in Canada, we have about 50 societies that have done this. In the U.S., they're more like 70 societies. This one is from Family Medicine in Canada, and they all look like this. Actually, there are usually 5, but the family doctors in this case did 11, and they all read like this: don't do imaging for low back pain unless red flags are present. And then below it, they have a little explanation of why this is true. They're all based on rigorous scientific data, which we help them do. On the back, the bottom of the sheet, there are references for each of these. So number 5, don't do annual screening blood tests unless directly indicated by the risk profile of the patient. So not doing that annual blood panel. So these are typical. This is what they look like. And many countries around the world have emulated this kind of format. It shows you the sort of straightforward simplicity of what these guidelines look like, or these recommendations. Here's another one just to give you a sense of another sort of more technology from cardiology. Don't perform stress cardiac imaging or advanced non-invasive imaging in the initial evaluation of patients without cardiac symptoms unless high-risk markers are present. And then below it, a little explanation of what that means, and then the references. So these are, there are like 180 of them in Canada. There are about 400 recommendations in the U.S. There are quite a few in Italy. It sort of depends on how long a country has been doing it. But sorry about that. So just to give you a sense also in Canada, I wanted to show you what percentage of all the recommendations are tests, treatments, and procedures. And as you will see, the blue box, the blue part of this pie chart is treatments, and the purple side is tests. And so those are all the, those are mostly technology. In fact, 20% in Canada of all the recommendations, not surprisingly, are imaging procedures. So I just want to shift and talk a little bit about the patient education side because, as I've mentioned, the reason that if you're going to have these conversations with your patients, it's a two-way street, and patients need to understand too. And so Consumer Report created, and we adapted in Canada, a lot of these pamphlets. And so here's an example of imaging for low back pain. And they all kind of look like this. They have a section called When You Need Them and When You Don't. And they explain, number 1, that they don't help you get better faster, and explain that. Secondly, they explain the risks. And I want to pause to say they're really super on this because they not only explain direct risk, like excess radiation from CT scans, they explain false positives. And patients really do not understand and often will say, well, what's the harm? Let's just get a test. But they don't understand the thing that health professionals understand, which is, if you have something on your x-ray, chest x-ray, You may then get a CT or MR to clarify it, then you might get a needle biopsy, et cetera, when the first test was in fact not needed, and you suffer a lot of harm really from the additional unnecessary tests. So they explain false positives. They always say when they do make sense, because we're not saying never do them. And then lastly, they have good material about what you should do to treat your low back pain. So they always give patients sort of tips to help yourself. And we really adapted these, but expanded some of our education to patients in a way I'll show you. So this is our new patient education campaign in Canada to play on that more is not always better. We think that society has a more is better kind of viewpoint, and that, you know, people equate that to healthcare. And so we've gotten some funny imagery to sort of engage patients in the understanding that more is not always better, including this hot dog with too much mustard. And we've created websites, et cetera, to try and help educate. We've created questions that patients could ask. Do I really need this test or treatment? What are the downsides? Are there simpler, safer options? And what happens if I do nothing? And what we've tried to do is to get these posters, the patient pamphlets, these 4 questions, videotapes into primary care doctors' offices. Since in Canada, that's where our patients do, you know, have their first sort of interactions. We think that this is an efficient way to reach the public. I mean, we don't have enough money to do huge public education campaigns, so this is one of the things we've done to try to reach patients where they meet with their family doctor and equip the family doctor with these materials so that, you know, it can stimulate this kind of conversation. And what we hear back from doctors that's so great is they say, this is really, we get notes from them, this has really changed my practice. Because instead of me, Wendy, telling a patient you don't need that MRI for low back pain and here's why, I could now say, and here's what these wise bodies, these experts, here's some material. It's not just me, it's scientifically based, here's the background. And that allows a different kind of conversation so that patients don't think that they're not getting the test, and this is key, because there's some rationing agenda. You know, if patients think we're withholding care because of any kind of pressure on us, they are not trusting. But if they feel we're making that decision with them because it's not in their best interest to have that test, it could actually be harmful to have that test, it's a whole different kind of conversation. And so you can see in all of the materials, both in the U.S. and Canada, that we are really focused, again, on quality and safety, prevention of harm, and it's never framed in a cost or cost-constraining kind of framework, because we know that both doctors and patients trust the message more when it is really about delivering good care. So there's a variety of different strategies people are using. Australia has done some really clever videotapes that you might find, you know, look at YouTube, and people are sort of developing different mechanisms to educate the public. So I want to say something about the implementation, because you all, of course, all know the challenges in translating knowledge into practice or knowledge translation. You know, we might have wonderful guidelines, but it's very, very difficult, as you all know, to get people to put them into action. So, I mean, we think of this as a sort of spectrum of implementation, ranging from engaging leadership in an institution, which could be a hospital, a region, a family practice clinic, and patient and physician education. So we give a lot of talks in different settings. And of course, these are very important and they're essential, but they're not sufficient for change. At the other end of the spectrum, there's what's evolving a lot, which is hardwiring this choosing wisely recommendations into electronic medical records in one way another, particularly in physician order entry, computer order entry, where I'll show you some examples of how things could pop up right at the point of care and obviously have an opportunity then to influence how the physician orders things. And certainly policy changes that, you know, can be a lever at that to delist things, but that's sort of not our approach, as I've mentioned. And in between, there are a whole variety of, you know, efforts that are more on the ground, quality improvement projects, measurement that shows variation within a region, which we use a lot, and audit and feedback, which I think is also really powerful. One of the best things about physicians is they're very competitive, and that can be used to our advantage, because if I see that the guy down the hallway is doing better than me, it's my professional pride rather than being paid or penalized. It's, you know, it really harnesses my desire to be better. And so we think audit and feedback is also a very powerful tool. And, you know, and in reality, using all of these things is a much more effective way to create change. Physician, you know, leadership, physician engagement, quality improvement, and physician order entry, like a whole spectrum of things go in, I'd say, to the organizations that have had the biggest impact implementing Choosing Wisely. So I'm going to give you some examples. So this comes from Cedars-Sinai Hospital in the United States. For those of you who don't know, this is the place movie stars go to get their care, and they get lots of care, much of which is unneeded. It's a very expensive place. And what they did is they, over time, have embedded almost all of the Choosing Wisely recommendations that are relevant into their CPOE, their physician order entry. Here's an example of a screenshot. So if you're at Cedars-Sinai and you go to order a benzodiazepine, which is a sedative hypnotic in a patient over 65, you get the American Geriatric Society recommendation that tells you that the number needed to treat is 15, the number needed to harm is 6, and you can override this or you can accept this and not order the benzodiazepine. 50% are overridden, but basically they've been at this for quite a while. They show changes, decreases in the ordering of these issues that come up with Choosing Wisely flags of ranging from 5 to 30%. And they've shown that consistently time over time. So this is an example of that. Here's one that comes from Washington State in the northwest of the United States. What it is maps of imaging for uncomplicated headaches. So how often do you have that example I used earlier, a patient that says, I have a headache, I want a CT scan, or the doctor is leaving no stone unturned. You can see a map actually for Medicaid payers, but if you look at either one, the commercial left, you see that there's some regions that are at the state average, that's green, or better than the state average, at the state average, which is yellow, and worse than the state average, which is red. And so what you can see is whether you get a CT scan for uncomplicated headache depends on which county you happen to live in. And overall, about 25% of patients, you know, in this circumstance get an imaging procedure that is possibly unneeded. So, you know, this is the kind of variation that won't surprise you. You've seen this in many other circumstances, but I'm showing you that it's being used in sort of the Choosing Wisely recommendations. In Canada, we have tried to engage people with developing toolkits, and I'm going to show you a variety of them and some of the results. We think that we don't want people to have to reinvent the wheel, so we tried to take common topics and develop toolkits on them. So I'll give you a few examples. This is one of our hospitals in Toronto. They were one of the early adopters of Choosing Wisely, and I just want to give you a sense of their impact. So this is the busiest emergency department in Canada. And so they started working on their emergency department. That's what ED stands for. And this has continued. They have decreased all of the lab work done in emergency departments by 40%. Now, you might ask, like, how would you possibly do that? And the reason is that often patients will walk in, and before the physician has even seen the patient, the receptionist asked why you're there and checked off some panel of blood draws that just become almost automatic. They've decreased the routine screening in their preoperative clinic by 40%. That's often low-risk patients that get EKGs, chest x-rays, et cetera. All inpatient laboratory testing by 5%, imaging, CT imaging by 5%, and ICU chest x-rays by 20%. That's the order I used to write, you know, chest x-ray daily. They've sort of stopped those automatic orders. So their approach is multifactorial. They have physician leadership. They have electronic order entry. They have a patient panel that's been very involved in implementing these recommendations. So we've created these packages. Here's one on the use of proton pump inhibitors. We have cute names for them, bye-bye PPI, examples where hospital has decreased their patients prescribed PPIs by over a quarter and reassessed over 90% of their patients as to whether they need them. Here's an example where a hospital worked on decreasing the use of urinary catheters. These get placed and then left. There's an increased incidence of urosepsis. This package is called Lose the Tube to try and help stop the placement and and implement withdrawal. They followed up, and of course, no negative impact on patients. In fact, they're preventing serious infections. Here's another example, important one. Many of the recommendations focus on the use of red blood cell transfusions, a precious resource, often overused. Frequently, physicians will write, transfuse 2 units of red blood cells. And many of the recommendations say only give 1 and then reassess whether the patient needs a 2nd unit, except in the circumstances, of course, where someone is bleeding. So this package is called Why Give 2 When 1 Will Do? And we have examples here of where one hospital decreased almost by 30% their blood transfusion rates, and in Nova Scotia, a whole province, decreasing by over 16%. So I want to just say another word away from the packages and implementation to something I really dearly love, which is we are engaging medical students in this campaign. We feel the long-term goal is a culture change, both on the medical side and the patient side. We had a group of students come together who you see in this picture, and they created an organization called STARS, and STARS stands for Students and Trainees Advocating for Resource Stewardship. And the funny fingers they're holding up are C's and W's, standing for Choosing Wisely. Because the students came together and said, you know, we see all these things that we ourselves do that don't make sense, like ordering. I'll show you an example, and they created a list of 6 things medical students should question, and now we've trained them, and they are going back. There were some from each of the medical schools in Canada. There's 17 medical schools in Canada, and we had 2 students from each come to this training session, and now they have a very vibrant social media campaign and are working on putting this into their medical school education. And of course, you know, this is the long-term goal, because if we can get away from the culture in medical education where we order everything to ensure we've been thorough, then ultimately we think they will practice differently because, like I said, you learn these patterns early in your training. So I'll just show you their list, for example, 6 things medical students and trainees should question, and just looking at number 6, for example, don't suggest ordering tests or treatments preemptively for the sole purpose of anticipating what your supervisor will want. And I can tell you, anyone who's been in medical training has done that. You know, Dr. Jones, my supervisor, likes to see the results of the MRI. Let's just get it tonight so when he comes in tomorrow, I look like I've done everything. And so we need to change that culture, so we're working there. Okay, so turning to evaluation or measurement, You know, we think measurement is not just about changes in utilization. We understand that governments and payers are most interested in whether we reduce the use of low-value services. But we think it's really, you know, provider attitudes, patient attitudes are very important also. But given your interest, I'll show you some of the work really on the utilization so you see what's happening. So just to give you a sense of Ontario, for example, we have picked priorities in both hospital care and in family medicine. We're working with our information systems in Ontario and targeting preoperative testing. This is in low-risk patients, and I'll show you some of our preliminary findings. And in family medicine, we picked four or five of the recommendations related to pap smears in ages that are not needed, imaging for low back pain, the MRI one, DEXA scans for bone density at less than a 2-year interval, and looked at the use of proton pump inhibitors and benzodiazepines. So we've picked some priorities. We've also, on the hospital sector, we're doing the transfusion one too. So just to give you a sense of this, what we find in Ontario, and this has Alberta data too, because remember we're provincial, these bars show the amount of testing for patients who are undergoing very, very low-risk surgery. This is all outpatient surgery, like an inguinal hernia repair in a 20-year-old, patients who clearly, you know, would be unlikely to need a lot of testing. And what you find, if you look at the teal bars, for example, is that 30% of them, these very low-risk patients, get an EKG. Fewer get, you know, more invasive tests like echoes and stress tests. Some get chest x-rays. But look at this next slide, which is, of course, so interesting. Overall, 30% get an EKG, these low-risk patients, but every one of these dots is a different Ontario hospital. And so in some hospitals in Ontario, 3% of patients get an EKG who are low risk before surgery, and in some, 90% get it. And the biggest predictor is not their comorbidities, but simply which hospital you happen to go into. So, of course, you can see that this is a perfect circumstance for us to use audit and feedback to try and get information back to hospitals and have them examine, why is this happening? Is this just in a routine order set that's leading people to get this automatically, even though it's not useful? Might even be harmful because it could delay surgery from false positives, for example. And we see this in all the things that we've been looking at in primary care and in hospital care, and are using it for audit and feedback. We're working with the Canadian Institute of Healthcare Improvement, the Canadian Institute for Health Information, to get to look at a variety of markers across the different provinces in Canada, again, to look at comparisons and find where we can create that healthy competition. So I'm going to shift from Canada to say a little bit about international, because I do want to leave time for questions. So, I mean, what's really exciting is that there are now actually 17 or maybe 18 countries implementing Choosing Wisely. Since its inception in 2012 in the States, we started in 2014 in Canada. But, you know, here's some of the campaign names. Italy calls doing more does not mean doing better, though they're switching to Choosing Wisely, I think, because it's been such good wording. The Netherlands has a program, Switzerland, Smarter Medicine. I think there might be someone on the phone from Switzerland. There's Japan, Australia, New Zealand, England, Wales, Brazil, and we've been in many of the European countries, of course, France, Switzerland, Austria is getting engaged. So we have been meeting annually for the last 3 years to try and share with one another. And what's very exciting now is we're starting to work with the Organization for Economic Cooperation and Development. And, you know, what we've done is we're sharing best strategies for implementing the campaign, trying to look at barriers, but we are starting to do, as I'll show you, some cross-country comparisons with the help of the OECD. I just want to show you briefly, I won't dwell on this, that we have developed a list across all the countries of the top 10 choosing wisely recommendations that seem to be actually in every country. And so we work off of this, and none of them would surprise you. Sorry about that, it's a little sensitive. So the OECD, and you might have seen this in the November Health at a Glance report, they've been working with us to take 3 measures of overuse and to start doing cross-country comparisons. So these are imaging for low back pain, antibiotics for viral infection, and benzodiazepines in the patients over 65. Now, we don't have, right at the moment, we have volume data, but we don't necessarily in each of the countries have linkage to clinical indication like the low back pain. So I'll show you some examples of what they do have, but we are working to sort of improve this over time with the help of Niek Klausinga, who some of you probably know at the OECD. So here, for example, is data that was published in their November Health at a Glance, looking at elderly patients over 65 prescribed long-term benzodiazepines or related drugs. And what you see here is the OECD average in per 1,000 patients, ranging from quite a high level in Ireland to much lower levels in other European countries and in Korea. So quite an interesting way to reflect on overuse, just as we've looked at quality indicators across many of these countries. We're starting to do this. Here's one more example. This is MRI exams, right up your alley of technology in 2013, looking at, again, variation in the per 1,000 population with very high levels in Turkey, I don't know why, and United States, I do know why, and then ranging, of course, across a variety of the European countries and other countries to look at how much MRI people are using. This is not, for example, linked yet to indication. It's just total volume. So that's work still to be done. Sorry. So, what are we learning from this international collaboration? It really is an emerging community. I'd say it's very telling and thought-provoking about the spread of choosing wisely across these countries, because a priori, I said to you, what would be so useful that it would be picked up at all of these countries? You would probably say, and I would have said, oh, our countries are so different. Our healthcare systems are structured so differently. We pay physicians so differently. How would it be that it would be picked up? And I think the reason is it is not structured based on the healthcare system. It transcends the healthcare system. It is really about what physicians do with their patients every day, which is help make good decisions based on quality and safety and harm prevention. And so, it just transcends the countries. It doesn't matter how you're paid. It doesn't matter really how the healthcare system, it is the work of doctoring. And I think that is why it's had this just remarkable uptake across so many countries. And I can tell you in Canada, the physician buy-in is just enormous. We had our first meeting, we were oversubscribed, we had tons of abstracts, and we just launched 2 years ago. So it just makes intuitive sense to physicians, and it isn't top-down, it's physician-led based on science. And so it's been very, very, I think, widely accepted. And of course, it has the patient side of the campaign that resonates also because, it is a dialogue, a conversation, and the campaign engages patients in a variety of different ways. And I think there are really great opportunities for us to look at measurement, working with the OECD in different countries. So I'm going to stop there so that we can take questions. So over to you.
Great. Well, thank you very much, Wendy. That was really an interesting presentation, and particularly interesting, as you say, about engaging the medical students and making that culture change a bit earlier on in these new doctors that are coming out onto the scene. So that's a really interesting approach. So I'll open it up for questions, as Wendy says here. So if you have a question, please feel free to type it in the chat or the Q&A box, or you can raise your hand and I can take you off mute and you can just ask your question directly to Wendy. So I'll give you a moment or two to think of your questions or to type your questions. In the meantime, I have a quick one here, Wendy, if it's all right. Of course, the HTA agencies in INAHTA are connected to regional and national government decision makers in the health system, or at that higher level reimbursement sort of decision-making level generally. And is there any connection? It seems that Choosing Wisely is connected, as you say, that grassroots, that clinician-led, the clinician organization there. Is there any communication or connection with the decision-making at the regional or national level within the health system as well? Is there any dialogue that you see going on between those two levels or groups?
Well, I mean, you know, we think that governments and payers have very blunt instruments for leading to these kinds of changes. Of course, you can decide not to pay for a new technology that doesn't add value. You can eliminate payment for an old technology that could be harmful. But payers, governments, decision makers, they're not in the exam room. So they can't say this MRI is indicated or not indicated because it's not part of the clinical conversation. And I would say overall, you know, well, there are some levers that decision makers, policy makers have. I'm sure many of you would say they're mostly frustrated that they can't really get bigger change. And when you step back and think about it, we've tried to be arm's length from those groups. Even though we've received some funding from provincial government, we have tried to have this be really led by doctors. And when I show you those slides that show 40% reduction in laboratory testing, I'm sure many of you were thinking, wow, that's amazing, as I was, because it's hard to imagine the kind of levers that payers have being able to have that kind of impact. So we have really tried to stay arm's length. I mean, I think the policy people, the governments are very, very interested in choosing wisely. But even though one of the Ontario government funded, we said, look, you have to stay at an arm's length and not interfere in this, because if you play too big a role, it will be seen as a rationing exercise or a cost containment exercise, and physicians won't buy in. I see there's someone that would like to ask a question.
Yeah, you bet. This is from Yanni Mueller. Let me just take her off mute here so she can ask her question. A second here, Yanni. Hi, Yanni. Can you hear me?
Yes. Hi, Tara. Hi, Wendy. It is really nice to hear your presentation. It was really interesting. Thank you so much. And I'm not a medical doctor. Actually, I'm a biomedical engineer. But I have, I have observed, I come from a middle-income country, and I've observed the mentality of the patients and also the doctors. Not only in the villages or towns, but also in the big cities. Patients are so, maybe that's the mindset. Patients are so dependent on the decision made by the doctor. If the doctor says you have to have a lab test or whatever, MRI, they'll say, of course, yes, that's what the doctor thinks, and he or she knows the best. That just was a comment, but I was wondering, why do you think that when the Choosing Wisely program came along, and even though the doctors may be at the back of their mind, or they really know that what they were doing is overprescribing or over tests or medicines. But when you all came along, how come then they changed it? Do you think because you're pinpointing their attitudes or showing them how it can be done in a better way, or yeah?
Yeah,
Thanks.
I mean, it's a very good question. I think all practicing physicians, and I must say I don't know quite how this operates in a middle-income country. It's mainly the higher income countries that we've worked in, although it is starting in other countries. But mostly physicians know that they do things that aren't needed, but they do them for all that host of reasons I mentioned earlier. And I think the campaign has given them an easier way to explain this to patients, to open this conversation. And because it has the patient education side, to help patients trust that. So you're totally right. Many patients will say, well, whatever my doctor says, I need it, so whatever my doctor says, I'm going to do. But I think that, you know, this is giving physicians permission, and it's also developing a kind of standard of care. So if an emergency doctor felt that they had to order an imaging of the abdomen when the patient had abdominal pain, and now there's some recommendations that say you don't have to, I think that's creating a standard of practice that also gives doctors permission to not order the things they think are not needed. So, you know, it's shifting, it's scientifically based, and it's also getting at the kind of barriers that we've had, that we've all known about, you know, that lead us to overorder. It really has resonated enormously.
Yes, you know, because some of the times it's the patient who would ask for some kind of a test or MRI or whatever imaging procedure, and the doctor, on the other hand, then can fall back on this and say, no, you do not really need it.
Right. Yeah, it's given them support.
Yeah. Thanks.
Great, thank you, Yanni. And any others? Any questions? Feel free, like I said, to enter in them in the chat or the Q&A, or just raise your hand and just give another moment or two here. Sometimes the typing takes a minute. It made me think a bit about the disinvestment discussions that, of course, happen at the payer level, at those kind of health system level decision makers, and it's a very different kind of approach. It's interesting to see that cost isn't a factor, and it makes sense. It would be difficult to include that in discussions and deliberations at the clinical bedside like that. So it's very interesting to see the progress that's being made in choosing wisely, and it's a different parallel to the disinvestment discussions that happen at the higher system level.
Yeah, I mean, I think the whole concept of disinvestment and the cost is something doctors really steer away from. You know, they don't like to, quote, ration at the bedside. We want to take care of the patient in front of us, and if they need an expensive test, we do it. So I think, you know, it's helped physicians to stay out of those conversations. I always say to payers and people like you, look, in some cases, it will save, a byproduct is that it will save money. So if you eliminate all those unnecessary preoperative tests in people who are low risk, that would be a real cost savings. If, on the other hand, you eliminate MRIs for low back pain, in Canada, where we have weights for our imaging equipment, it will not decrease cost. It will just mean perhaps that the queue for the MRI machine is less, or that more appropriate people are getting the technology they need, but it won't save money because those machines are used maximally. So, you know, that's a way to think about it. Of course, government is interested in that decreased utilization and the cost figure, but, you know, I think it's like if we don't transfuse blood, that has so many benefits. Blood is a precious societal resource. It's very expensive to hang a unit to do the crossing and typing and hanging that unit of blood with manpower. And, you know, it's a harmful thing. There are people who have volume overload from blood transfusions and who get blood reactions. So, you know, as a patient, you'd prefer not to have it if you don't need it. So it's sort of a win-win-win-win. It's good for the patient, it's good for society, it's good for decreasing costs, but it's the right thing to do. And, you know, the hospitals have really glommed onto the transfusion one as one that's, you know, very interesting to them. I think there's a question from...
Yes, I see that. They're great. Yes, from Heidi. So let me just read this out here from Heidi. So her question is, so how have these lists been produced actually? So you approached physician societies and got them to work on it? So just, I guess, some of the background on how. Yeah,
good question. I should have spent a little more time on it. So basically, we approached the medical societies. Every country did this somewhat differently, but with the same core concept. So in Canada, we would have gone to the Canadian Cardiovascular Society, the Canadian Radiology Association, you know, the Canadian Rheumatology Association. And we had principles for them. We didn't tell them how to do it, but we, you know, principles, common things in your specialty. We didn't want the specialties to be saying family practice doctors shouldn't do this, but we ourselves shouldn't do this. We overuse this and or overorder this. And they were all based on science. We provided in Canada support through Canadian Agency for CADIS, Drug and Technology Assessment in Healthcare, who do rapid reviews. So we could provide some help to societies if they didn't have a lot of staff. And many of them created a task force. They sent these recommendations or a larger number out to their whole membership and got their members to vote on them. So many of them used a sort of consensus process, which was both engaging their physician membership and educating their physician membership. And then what's been great is many of them actually have put this on the agenda for their plenary sessions at their annual meetings, or put them in their publications. So we've worked, the societies have been very, very important. And once the ball got rolling, it was very easy to engage other societies. We didn't have to go get them. They called us and said they wanted to participate. And so that has not been difficult to do.
Great. So Heidi, I hope that answers your question. If you have a follow-up, please feel free to just enter it there in the text. Anyone else, any other questions or comments for Wendy here? I don't see anything further coming up in the chat, or, oh, there we go. Nadine has a question. Great. So her question is, Dear Wendy, thank you for the interesting presentation. I was wondering to what extent doctors do additional or unnecessary tests for their own security. I'm also wondering how the attitude is as concerns additional remuneration when doing tests.
Yeah, so, you know, I think the thing is, this probably a little bit depends on the test and the health system, how this plays out. As I mentioned, emergency room physicians, for example, are extremely sensitive to malpractice. They don't have a long-term relationship with patients. They see high volumes quickly. And in that setting, they do a lot of tests, as you would say, for their own security, meaning to make sure they've left no stone unturned. In other situations, I think there are, for example, in Canada, cardiologists get paid to read echocardiograms, and so it's remunerative to read echoes. I am not naive as to think that that doesn't play a role. It clearly does, but I really think it's a lot about the way they learn to practice, and that overrides a lot of the other things. And I think what you can see in this presentation is we are trying to appeal to physicians' professionalism. Their professionalism in terms of doing the best for their patients, doing it based on science, and, you know, and engaging them in the conversation. And we think that really appeals to physicians. And we think that's been why it really speaks to their sense of professional pride. And so audit and feedback and giving them information at the point of care. So you're totally right. These factors play a role. I don't diminish that. But we think that the traction is coming from that doctors really know this is the right thing to do, and it's very easy to do what we're suggesting. It's not complicated, as guidelines can be sometimes complicated to wade through and understand and apply.
Great, thank you. And Nadine, again, if you have any follow-up questions, feel free to just add them. Yeah, that's interesting. That's another contrast that I observed is the guidelines world, and how I've seen some guidelines, and they're very different looking than the one-pagers that you were showing with the sort of items, the sort of the numbered items on those sheets. That's an interesting contrast. Is there anything else you can say about the guidelines, or has there been any connection with the guideline world or complementary synergies there at all in this work?
Yeah, I mean, I think they are synergistic. You know, if you look at guidelines, the Choosing Wisely recommendations frequently dovetail with them because guidelines are also based on evidence. So, you know, in many jurisdictions that have taken up Choosing Wisely, including the one that you're in, they've taken the things they're already doing, you know, having a strategy on imaging for low back pain, if that was a pre-existing kind of strategy or there were pre-existing guidelines that they were trying to promote in their physician population, and just inserted Choosing Wisely, because I think because it's simple, and the branding of Choosing Wisely, I didn't talk a lot about that, but we think that the words, which were selected very carefully, also resonate with doctors and patients. So sometimes people have taken what they were already doing, including guidelines, and just kind of branded it as Choosing Wisely because of the sort of uptake in the physician community.
Right, the power of branding is very important. Absolutely. Okay, great. Again, just waiting here another moment or two if there's further questions. Anna has a comment. I don't know if it's a comment or a question. Let's just say, yeah, she just says, sorry she connected later, but she found it very interesting. And she says, congratulations, thank you.
Well, you know, I think I'm glad to present to you. I know that you come at a similar problem of overuse or inappropriate use in a very different way. And so I hope this sort of helps you to think, gee, where are some of the levers that are, you know, really embedded in the physician population, and it is complementary to what you're doing. And in many of the countries, I think, represented on this phone call, there are already beginning efforts or even well-established efforts in your countries to implement Choosing Wisely. And if any of you are interested in knowing who in your country is doing it, I'd be certainly happy to link you to those individuals that I'm aware of.
Great, thank you. That was one of my questions as well, is how do people find out more if they're interested? So there we go. People can contact you directly. That's great. Okay, any final questions or comments for Wendy? Again, I'll be putting the recording on the members area so you can review it if you missed the beginning, came in a bit later. You can watch the first half of the presentation, or if there's colleagues in your agency, they're welcome to view the webinar as well. And it looks like we're probably good for questions. So was there anything further, Wendy, that you wanted to say or comment before we sign off here?
No, I think, you know, I hope it's stimulating or thought-provoking people, and I'm easy to reach at the Choosing Wisely website, or my email address is wendy.levinson, just my name, at utoronto, University of Toronto, so it's just utoronto.ca for Canada. So I'd be happy to answer questions offline. Thanks for your attention.
Great. Thank you very much, Wendy. On behalf of the INAHTA family, we call ourselves, thank you very much for, like I say, your time and sharing your expertise and this really interesting and dynamic program that you have. And we look forward to connecting sometime in the future. Maybe our paths will cross again, or some of the INAHTA members you'll meet in different places here and there. So thank you very much.
You're welcome. Goodbye.
Bye-bye.